Thank you. Assalamu alaikum and good afternoon, everyone. I am Dr. Mohammad Rafiqul Islam, Associate Professor of Medicine, Shohid the Medical College. Today's my presentation is on approach to a patient with abdominal pain. First of all, you can see this is a magic box, and you say the patient, the sorcerer has this magic box. এবং আপনারা দেখেন যে একটা sorcerer বিভিন্ন জিনিস থাকে এবং abdominal structure আমরা জানি দিছি abdomen is also a magic box. So abdominal যদি কোনো পেইন হয় তাইলে সেইটাকে আপনার অ্যাপ্রোচ করা এবং টু ডায়াগনোস করা ইটস very difficult. It's like a magic box and you have to be a magician to find out the etiology of the abdominal pain. So let's check what is the anatomy of the abdomen. The abdomen is the part of the body which obviously between thorax and the pelvis, and upper surface is formed by the diaphragm, which separated from the thoracic cavity, and at the level of the pelvic bone, abdomen is separated from the pelvis. So, and boundary anteriorly, we all know is a thin but a tough layer of fascia, followed by abdominal muscle, and posteriorly, obviously, by the muscles of the back as well as the spine. So, important contents of the abdominal cavity is the digestive tract. All we know, alimentary tract. There is esophagus, stomach, and foregut, midgut, and hindgut. And there are some other part also, so non-alimentary tract viscera like liver, spleen, gallbladder, pancreas, kidney, many things. And vessels, abdominal aorta branches, inferior vena cava, and lymphatics. This all are part of content of the abdominal cavity. So abdominal pain can happen to pathology to any structure, like the digestive tract, like the viscera, like the vessel. So we have to keep it in mind. So if you see the surface marking of the abdominal structures, where is the point of esophagus, fundus, and you check the number 4 is the duodenum, as well as you check the appendix, and you check transverse colon, and also cecum and sigmoid colon. And in the right side, you can check the liver, spleen, pancreas, and gallbladder. Frequently, we get problem in the stomach, appendix, liver, pancreas, gallbladder. So we have to understand the surface marking of the structures. So abdominal pain may be due to visceral pain. What is visceral pain? Visceral pain is transmitted by nociceptor or stress receptor. The stressing of the viscera will produce some pain. And somatic pain, as all we know from the abdominal wall and also from the parietal peritoneum. So anything happens in the abdominal muscle or parietal pain, we all know the parietal peritoneum is pain sensitive. So pain can happen. Abdominal muscle is also pain sensitive, is somatic nerve, and visceral pain occurs due to stretching of the receptor or by nociceptor. There is also some pain like referred pain. We have to understand the referred pain or the extension of pain to another side while it exists in the primary side. There is a primary side আপনার pain হবে, তার সাথে এই পেইনটা একটা এক্সটেনশন আসবে অন্য একটাতে জায়গাতে। যেমন ধরেন gallbladder pain that may refer to the back or shoulder tip. Scapular lower part এ আপনার এই referred painটা আসে, অথবা দেখা যাচ্ছে gallbladder pain, right hypochondriac pain, আমরা একটু আগে surface marking দেখলাম যে gallbladder pain in the right hypochondrium, and pain may refer to the shoulder tip. So whenever we think a patient with right hypochondriac pain, we have to take the history of whether patient having right shoulder pain or in the pain in the lower part of the scapula. And some also patient have psychogenic pain, not due to any organic cause. I will come into that. Some other pain also terminology is also there, like radiating pain. Pain is felt in a distance from the source of the pain. Like আপনি দেখেন যখন আপনার cardiac pain আসে, যদি abdominal আপনার cardiac pain আসে, তখন sometimes felt in the jaw. So there is also some radiating pain. You have to understand pain may not present in the original side, may present in the distant side, and shifting or migration of the pain. Pain is felt at one side, then it shifted to the another side. Like in the appendicitis, you can see patient pain predominantly felt in the periumbilical area, and at the later part, pain shifted to the right iliac fossa. So you can see this picture, that patient, different type of radiated referred pain. Check this patient having referred pain. In that, look at this thymus pain you can see here, and patient having cardiac pain that referred in the shoulder as well as the left hand, and patient having liver and gallbladder is checked. In the back, patient having pain in the appendix. In the large area, patient have appendix. Patient have kidney pain. You can see in the back and this area, patient have a bladder pain, urinary bladder. You can check urinary bladder pain in the back of the buttock. Patient having ureter pain. Patient feels pain inner part of the thigh. So patient have renal colic, may pain radiate to the referred pain comes to the inguinal area also. So what could be the etiology of the abdominal pain? So if you can, more than 1,000 causes exist. So that's why it is a magic box. The 1,000 causes, can you imagine abdominal more than 1,000 causes exist for abdominal pain? It's terrific. So it's a non-specific pain. Abdominal pain is 34%. And the case of acute appendicitis is 28% pain. All abdominal pain are due to acute appendicitis. And 10% pain due to acute cholecystitis, and a small bowel obstruction for 4%, perforation for 3%, and pancreatitis for 3%, and diverticular disease for 2%, and many more causes of others for 13%. So keeping in mind that non-specific abdominal pain consists of 34% of the abdominal pain. So whenever we think about how I will approach a patient with abdominal pain, so we always think about the name of Socrates. The Socrates, this can lead the proper history taking to approach to a patient with abdominal pain, right? The site, onset, character, radiation, associated symptom, timing, exacerbating and relieving factor, and severity. So whenever a pain comes to in your mind in the examination table, always remember Socrates. Don't forget about Socrates. So let's check up the site of the pain. You easily can say right hypochondrium abdomen is divided into 9 parts: right hypochondrium, epigastrium, left hypochondrium, right renal, left renal, umbilical area, right hypochondrium, right iliac fossa, left iliac fossa, and hypochondriac area. So how will you differentiate between different type of pain? In case of visceral pain, you can see it is poorly localized. And then if the pain comes from the gut, it's poorly localized in the midline. Pain from the distension of the hollow viscus, or either or due to mesenteric traction or excessive smooth muscle contraction, it is poorly localized as because it is somatic, not somatic pain. It is visceral pain. But in case of somatic pain, which arises from the anterior abdominal wall or from the peritoneum, it is lateralized and localized. You can keep the touch and feel the tenderness on the specific area. That is somatic pain. Pain arising from the foregut usually comes from the stomach, pancreas, liver, biliary tract, or localized above the umbilicus. And center of abdominal pain arises usually from the midgut area, like small intestine and appendix, and hindgut structure give rise to the lower abdominal pain. So pancreatic pain, the most difficult pain is pancreatic pain. Whenever a patient with abdominal pain, we medicine doctor first exclude whether it is pancreatic pain or not. If it is suggestive, history suggestive, we first think about whether we are dealing with a case of pancreatic pain or not. Pancreatic pain usually feels the midline and radiates through the back. We all know patient remains in a Mohammedan's position, patient leans forward, and patient have a history of alcohol and different things. So we all know about the pancreatic pain history. In case of renal colic, if you think about renal colics, felt as well the radiate in the affected side. Renal colic is in the, if it is right renal colic, then you will feel the pain in the right renal area, and you will see patient will have a radiating from low to groin pain. In case of liver, you will find the dull, throbbing or dragging pain in the right hypochondriac area. In case of splenic pain, you will find some pain in the left hypochondriac area. It's a dragging pain. But if there is an infraction, you will not feel the pain. This is called a severe acute throbbing pain in the spleen. So what is the etiology behind the cause of the pain? We will find out the type of character of the pain. In male, torsion of the testis may present with abdominal pain. Don't forget about the torsion of the testis. In female, never ever forget about rupture ovarian cyst, ectopic pregnancy. Young lady in a reproductive age, married lady, sudden severe abdominal pain, is getting hypotension. Never ever forget about ectopic pregnancy. Please don't forget. We lost many lives due to failure of thinking of ectopic pregnancy. Pelvic inflammatory disease, endometriosis. In Rajshahi Medical College, we found a case. Patient was unmarried and acute abdominal pain, young lady. We didn't think of a case of ectopic pregnancy. Eventually, we again evaluating why patient have so severe pain, we cannot find out the cause. Then we took a heroic decision to give a injection needle in the abdomen, and we aspirate blood from the abdomen. Instantly, we found that this is a case of ectopic pregnancy. And then we reviewed the history again, and she gave us the history of relation with others. So never ever forget a young lady, reproductive age group lady with severe lower abdominal pain with hypotension. Never ever forget about ectopic pregnancy, whether married or not married, doesn't matter. But keep in your mind. So this is the foregut pain localizing in the epigastric area, midgut pain localized in the periumbilical area, and hindgut pain localized in the suprapubic area. And the onset of pain. The onset of pain is sudden or acute onset. So sudden or acute onset pain can be due to perforation of the gas-containing hollow viscus, rupture aortic aneurysm, or mesenteric ischemia. Sudden, severe, acute. And sometimes it can be due to pancreatitis. And chronic pain, periodic exacerbation and remission. We all know periodic exacerbation and remission. This is a typical history of peptic ulcer disease and relation with food. This is peptic ulcer disease. And sometimes occurs in the large bowel obstruction. It causes the chronic pain build up slowly in the large bowel obstruction. Patient with IBD, inflammatory bowel disease, and also in IBS, patient causes pain, the chronic exacerbating pain. So now comes to the character of the pain. So pain is a colicky pain, constant pain. What type of pain you must, in the case of colicky pain, try to understand, ask the patient whether patient having colicky pain in the abdomen or dull constant pain. If patient have a colicky pain, think about something obstruction occur in the any tract like gas containing hollow viscus, or in the biliary tract, or in the ureter, or in the fallopian tube. Something there is obstruction in the tube, or either in the gas containing tube or any other tubes in the abdominal cavity that will produce colicky pain. A dull, constant, or vague, or poorly defined pain also you'll find usually indicates an inflammatory or infective process. Either inflammatory, like what is inflammatory? IBD, inflammatory bowel disease, or infective process, such as patient having peritonitis, patient having appendicitis, patient having diverticulitis. This will produce infective pain, and inflammatory pain will occur in inflammatory bowel disease. Patient may also cause sharp pain, sharp, severe pain. Patient complains of sharp and severe pain, catastrophic pain, and patient having BP down and asymmetrical femoral pulse. You'll always think about rupture aortic aneurysm. Patient having severe acute sharp pain, patient having asymmetrical femoral pulse. Never forget about rupture aortic aneurysm. That's why you must check the femoral pulse in the severe sharp acute abdominal pain. So there is a radiating pain. You can see the right shoulder. You can see the pain radiating from the diaphragm. It's in the shoulder. Can also radiate from the patient from the gallbladder problem. So this is called as a phrenic nerve. The distribution of the phrenic nerve in the diaphragm as well as in the tip of the shoulder, that will produce gallbladder pain or diaphragm pain to the right shoulder. And as you also find that patient in gallbladder problem, you will find pain in the lower part of the tip of the scapula. In case of splenic rupture, you will find the pain in the left shoulder. And in case of whether you are seeing under renal colic or ureteric obstruction, you will find pain in the loin to groin radiating to the genitalia, low ingrowing pain. So check at the radiation pain. The stomach pain usually side is epigastrium, but it can radiate to the right hypochondrium. Of course, right hypochondrium is the duodenum is tilting towards the right hypochondriac side. The lumbar side of right iliac fossa, even in the left side of the chest, many times patient comes with the left chest pain. Tell me, doctor, I'm having cardiac problem, but আমাদেরকে অবশ্যই চিন্তা করতে হবে যে right cardiac pain is usually in the central position, not in the left sided position. And vertebral column, even radiation stomach pain radiates to the vertebral column. Right of lobe of the liver is always felt in the right hypochondrium, as well as shoulder, right supraclavicular, and as well as scapula. Left lobe of the liver, patient feel usual site is epigastrium, but may refer to the precordium, left scapula, and left clavicle. Don't forget about the left scapula and left clavicle. And gallbladder pain, the failed. Sometimes many patients who comes with epigastric pain, we think about the peptic ulcer disease, but eventually turns out to be a case of gallbladder stone. So chest, intercostal region, right clavicle, shoulder tip, as well as in the back. The pancreas pain, epigastrium, and back. Renal colic, low into going pain, we all know, may even to genitalia. Appendix pain is central or umbilical pain, and shift to the right iliac fossa eventually. And ovary pain, sometimes in the right ovary, it will feel right iliac fossa, left ovary, you can feel in the left iliac fossa is the primary side, but radiating pain to the external genitalia. So always Socrates is associated with symptoms. Some symptoms are associated. In case of abdominal pain, anorexia, nausea, vomiting are common, but usually it is non-specific. But sometimes it can be specific. Like if you patient having gastric outlet obstruction, peptic ulcer disease with gastric outlet obstruction, patient will have a pain in the epigastrium as well as tremendous vomiting tendency. Patient having acute papillomatosis, acute pancreatitis, patient may feel pain in the epigastrium as well as vomiting tendency. Patient have a gallbladder stone, patient may pain in the epigastrium as well as epigastric vomiting tendency. So altered bowel habit may also be associated with irritable bowel syndrome. We all know colorectal cancer, intra-abdominal tuberculosis. So bowel habit, we should ask about the bowel habit of the patient. So whether patient having high-grade fever or not, we must discuss about this. In case of high-grade fever, we think about patient having abscess or patient having any source of abdominal abscess can produce this source of high-grade fever, and patient also have enteric fever may cause right iliac fossa pain as well as in the high grade of fever. Hypotension and tachycardia may associate with abdominal pain. You must think about sepsis or intra-abdominal bleeding. So timing is very important. The pain pattern and timing of the pain is very important. Let's check what is this. In acute small bowel obstruction or strangulated hernia, initial colicky pain is replaced by persistent pain with tenderness, a suggestive of intestinal ischemia. Initially, intestinal obstruction or strangulated hernia, patient have colicky pain, but eventually patient have if the strangulation, if the obstruction is lingered, then patient may have ischemic feature, and this time patient will produce consistent pain. And after the perforation of 1 to 2 hours of perforation, patient have no pain at all. And after that, patient will regain the pain, as initially in perforation of the gas containing hollow viscera, patient may present with chemical peritonitis, and eventually chemical peritonitis will be replaced by bacterial peritonitis that will be diffuse pain. So some exacerbating and relieving factor. Pain related to the ingestion of food is the gastric ulcer. Pain relieved by food taking, duodenal ulcer. You all know. Pain relieved by vomiting, gastric outlet obstruction. Pain on recumbent position and relief on erect posture. Of course, it is gastroesophageal reflux disorder. Pain in fatty food ingestion, that shows malabsorption as well as pancreatitis. Pain on defecation is indicating patient having colonic disease. Pain during passage of food or food for digestion or absorption is intestinal angina. Patient having intestinal angina. I'm coming to intestinal angina. So what is the severity? You can severe grading, we can say this is mild, moderate, severe, or excruciating pain. So usually mild pain we can see in cases of IBS, in case of inflammatory bowel disease, or mild PUD. In case of IBD, it can be severe pain, can be mild pain, can be moderate pain. In case of IBS, usually it's milder pain, but can be moderate pain, but never ever severe pain. But peptic ulcer disease can produce mild, moderate, and severe pain as well. In case of moderate case, you can see the appendicitis pain, pelvic inflammatory disease pain are moderate type of pain. Severe pain usually rapidly mitigated by analgesics like acute pancreatitis or peritonitis. There are some excruciating pain, which is poorly relieved by opioid like inflammatory bowel obstruction or rupture abdominal aortic aneurysm. So in case of excruciating, poorly relieved by opioid, think about bowel infarction, that is mesenteric ischemia or ruptured abdominal aortic aneurysm. So whenever you find a patient with generalized abdominal pain, think about perforation, abdominal aortic aneurysm, acute pancreatitis, diabetic ketoacidosis, and bilateral pleurisy. Yes, in case of bilateral pleurisy, bilateral pneumonia, you can find this pain. What type of pneumonia? This bilateral basal pneumonia can produce pain in the generalized pain in the abdomen. In case of central abdominal pain, you can find in early appendicitis, small bowel obstruction, acute gastritis, acute pancreatitis, rupture aortic aneurysm, and acute mesenteric thrombosis. It can produce central abdominal pain. In case of epigastric pain, you can see the picture, the blue color picture, see due to epigastric pain. You all know epigastric pain due to, we first think about the peptic ulcer disease. This can also occur esophagitis, biliary colic, and acute pancreatitis, and abdominal aortic aneurysm. If you feel the pain in the right upper quadrant, you always think about the liver is situated in this area. So anything related to the liver and liver-associated factor like gallbladder, liver abscess, you can find pain in that area. Duodenal ulcer disease also is a feature, and right basal pneumonia, and subphrenic is a right-sided subphrenic abscess. Left upper quadrant, think about gastric ulcer disease, left basal pneumonia, acute pancreatitis, and of course, don't forget about subphrenic abscess. In case of left upper quadrant pain, we always feels problem. What could be the cause? So don't forget about the gastric ulcer disease, and of course, you will say pancreatitis, and never ever forget about left-sided basal pneumonia and subphrenic abscess. What about the suprapubic pain? We all know this is the place of urinary bladder. So acute urinary tract obstruction, UTI, and cystitis, bladder inflammation, infection, peptic ulcer, PID, pelvic inflammatory disease, and ectopic pregnancy and diverticulitis. Never forget about the diverticulitis. So right iliac fascia, the most common area. We always think about, we are very much happy with finding the patient having acute pancreatitis. Number one, acute pancreatitis. So one of the important cause of abdominal pain is acute appendicitis. So mesenteric adenitis, that's a large lymph node in the mesentery, enlarged lymph node. The one of the beauty of mesenteric adenitis, if a patient shift on the left side, it will produce pain in the left side. If patient shift on the right side, patient will produce pain in the right side. If patient stands, the pain will go to the down. Patient is in upside down, patient will feel the above side. So mesenteric adenitis pain will move with the movement of the patient. And in case of perforated duodenal ulcer, patient the right iliac fossa pain, diverticulitis, pelvic inflammatory disease, sulfinghitis on that side, uretary colic on that side, and Michel's diverticulum. All the Michel diverticulums remain in that side. And ectopic pregnancy, never forget about ectopic pregnancy on the right-sided fallopian pregnancy, and fallopian tube pregnancy, and Crohn's disease. And left iliac fossa, we always feel problem. We all know the cause of right iliac fossa pain, but whenever you are asked to tell me some causes of left iliac fossa pain, we all shudder. What happens? Well, I don't know. I cannot say anything. So don't forget about the diverticulitis, constipation, pelvic inflammatory disease, ulcerative colitis, ectopic pregnancy, PID, rectal carcinoma, and sometimes in irritable bowel syndrome. Don't forget diverticulitis, constipation, carcinoma. And what about the loin pain? Sometimes patient pain comes with the loin pain. The premier cause is muscle strain. Premier cause is muscle strain. And then urinary tract infection, renal stone, and of course, pyelonephritis. In case of pyelonephritis, you can push the renal side and corresponding renal side, and you'll find renal angle tenderness. So this is as a whole what I have told you just before. And there are some non-elementary cause of abdominal pain as you get some myocardial infarction. In case of inferior MI, you'll find severe upper abdominal pain. So whenever a young patient or middle-aged patient or elderly patient, especially middle-aged patient and elderly patient comes with epigastric pain and telling, oh doctor, I am suffering from peptic ulcer disease, it's severe constant pain, I cannot get rid of this pain. Please, please, please do an ECG, 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 ECG. Never for lots of hundreds of cases, I have seen patient came with epigastric pain and eventually got the diagnosis of myocardial infarction. Many patients survived and many died due to undue taking of lingering the case by taking only antacid syrup or gastric omeprazole, that type of drug. So patient with epigastric pain without tenderness, angorrhea, there's a feeling impending death, hypotension and cardiac edema. Hypotension usually does not occur in the inferior MI cases. Hypotension usually occurs in the anterior surface myocardial infarction. The patient might have dissecting aortic aneurysm pain. It's a non-elementary, this is a tearing interscapular patient. Tell you that I have severe pain, the interscapular pain is something is tearing within my body. And angorrhea, that means the feeling of impending death, and patient having hypotension and asymmetrical femoral pulse. So any patient, I'm telling you repeatedly, coming with abdominal pain, don't forget about seeing pulse, BP, femoral pulse, bilateral femoral pulse. Please, please don't forget. So acute vertebral collapse can also come with abdominal pain, and cord compression can also occur patient with acute abdominal pain. Pleurisy bilateral lower lobe pneumonia can come with these sorts of problems. Herpes zoster can come with the patient having blistering lesion in the anterior abdominal wall, looking like the hell from the roses of hell from the roses of hell. The herpes zoster is causes of that is called roses from the hell. That is dojoge lal golap, red roses from hell. So diabetic ketosis, don't forget about diabetic ketosis. Patient will produce severe cramping abdominal pain with vomiting and air hunger. Air hunger is called Kushmal breathing. Patient having tachycardia and sweet odor in the mouth, that is called ketotic breath. So patient with abdominal pain, patient having history of diabetes mellitus, and check the patient having tachycardia, patient having air hunger, ketotic breath. Don't forget about diabetic ketosis. Your diagnosis, early diagnosis can make the patient survive. Never forget about the ketoacidosis. Don't think always patient having upper abdominal pain, this patient is suffering from peptic ulcer disease, patient is suffering from pancreatitis, patient is suffering from gallbladder disease, patient is suffering from the left lobe of the liver problem, something like that. But think about the other cause like inferior MI, think about diabetic ketoacidosis. So there are some extraintestinal cause of chronic and recurrent abdominal pain, like lymphadenopathy, abscess, depression. What I am telling this is, don't forget about the psychogenic cause like anxiety, depression, hypochondriasis, and somatization. Don't forget about hypochondriasis and somatization. And patient have a vertebral compression and abdominal muscle strain. Patient might have diabetes mellitus, acute intermittent porphyria. This is a disease. And hypercalcemia. You all know, in case of hypercalcemia, patient will say, patient have a stone, groan, abdominal stone, abdominal pain, abdominal stone, bone, stone, abdominal groan, and psychic moan. So patient will produce, in case of hypercalcemia, abdominal groan. So some drug and toxins are also related to abdominal pain, like glucocorticoids, azathioprine, lead and alcohol. A patient with alcoholics produce gastritis as well as pancreatitis. Patient may also produce cirrhosis. So hematological cause is sickle cell disease causes sequestration syndrome, the pain in the splenic area. Patient also have spinal cord disease, stapes dorsalis, and radiculopathy. So now come to what is hypochondriasis and what is somatization disorder. In case of hypochondriasis, this is a mental illness characterized by the excessive irrational concern for oneself. The patient, এই ধরনের পেশেন্টগুলি সাধারণত মনে করে যে তাদের আসলে কোনো একটা রোগ আছে যেই রোগটা কেউ ডায়াগনোসিস করতে পারতেছে না এবং রিপিটেডলি পেশেন্ট মনে করতেছে যেই পরিমাণ পেইন যেই রোগের জন্য হওয়ার কথা তার চেয়ে বেশি পেইন হচ্ছে, পেশেন্ট এক্সাজারেটেড রেসপন্স হচ্ছে। দিস ইজ কল্ড হাইপোকন্ড্রিয়াসিস। পেশেন্টের থিঙ্কিং এক্সেসিভ কনসার্ন অ্যাবাউট দ্য হেলথ। And what is somatization disorder? Somatization disorder is defined as a presence of physical complaint over a period longer. The patient একটা physical complaint হবে abdominal pain এর, যেটা 6 মাসের বেশি ধরে থাকবে এবং কোনো পার্টিকুলার ডিজিজ দিয়ে আপনি এক্সপ্লেইন করতে পারবেন না। পেশেন্টকে কোনোভাবে এক্সপ্লেইন করতে পারবেন না যে পেশেন্ট হ্যাভিং abdominal pain is not due to any structural disease or non-alimentary disease or any other disease, and consistent pain more than 6 months. পেশেন্টের সবসময় মাথায় ঢুকে রাখবে যে আমার একটা কিছু আছে, কেউ ডায়াগনোসিস করতে পারতেছে না।
স্যার এটা কি সাইকোলজিক্যাল?
Yes, psychological, definitely psychological. They'll take up the history of the past history. So a patient, any history of trauma, think about history of trauma, history of similar symptoms may suggest of diagnosis such as pancreatitis. Pancreatitis may be chronic pancreatitis, peptic ulcer disease, and wiring, coming and going, relation with food as a history. If think patient have a peptic ulcer disease. In case of aortic aneurysm or mesenteric ischemia, এই ধরনের পেশেন্টের সাধারণত আপনারা দেখবেন যে পেশেন্টের পেরিফেরাল ভাস্কুলার ডিজিজ থাকে, হাইপারটেনশন থাকে, হার্ট ফেলিওর থাকে, অ্যাট্রিয়াল ফিব্রিলেশন। ইজিলি ইউ ক্যান গেজ যদি একটা পেশেন্ট হার্ট ফেলিওর থাকে, অ্যাট্রিয়াল ফিব্রিলেশন থাকে, তাহলে সেখানে একটা থম্বাস আসার কথা। সেই থম্বাসটা চলে আসবে হচ্ছে যে মেসেন্ট্রিক আর্টারি, বেশি অবস্ট্রাকশন করে দিলে দেখবেন যে এখানে মেসেন্ট্রিক ইস্কিমিয়া ডেভেলপ করছে। সো পেশেন্টের যদি কোনো একটা থম্বোটিক একটা কিছু থাকে, যে পেশেন্টের হার্ট ফেলিওর আছে, অ্যাট্রিয়াল ফিব্রিলেশন আছে, কোনো অ্যারিথমিয়া আছে, তাইলে এই ধরনের পেশেন্টগুলির দেখা যায় যে আপনার মেসেন্ট্রিক ইস্কেমিয়ার একটা চান্স থাকে। পেশেন্টের অ্যাওরটিক অ্যানুরিজমের যে পেশেন্টের কনসিস্টেন্ট ডাইলেটেশন থাকে, প্রিভিয়াস কোনো সার্জারি আছে কিনা, পেশেন্টের অবস্ট্রাকশন থাকে, যদি আগে সার্জারি থাকে তাইলে বেন্ড এন্ড অ্যাডহেশন থাকে, তখন দেখা যায় যে পেশেন্টের একটা অবস্ট্রাকশন। সো কোন পেশেন্ট আপনি আসছে অ্যাবডোমিনাল পেইন, আপনি দেখছেন যে এই পেশেন্টের ফ্লুইড লেভেল আছে, এয়ার ফ্লুইড লেভেল আছে, আপনাকে হিস্ট্রি নিতে হবে প্রিভিয়াস তার কোনো সার্জারি হিস্ট্রি আছে কিনা, তাহলে আপনি বুঝবেন যে পেশেন্ট হয়তো ব্যান্ড এন্ড অ্যাডহেশন হয়েছে, আপনাকে একটা ইটিওলজি চিন্তা করতে হবে। So family history is also very important. In case of diabetes, cause, metabolic cause of the abdominal pain, coronary artery disease runs in the family, inflammatory bowel disease runs in the family, and the social history also very important. Dietary history, whether patient is vegan or patient realize আমাদের দেশে এখন অনেক মানুষ আছে patient takes only meat and beef and chicken, no meat, no fish, no vegetable. So these sorts of patient will eventually develop diverticulitis, patient will develop constipation, different sorts of problem. Some food intolerance is also there. Some patient have food intolerance like milk intolerance, patient produces diarrhea. Alcohol consumption produces with pancreatitis, we all know gastritis. Smoking causes gastroesophageal reflux disorder. Intravenous drug abuse produces intra-abdominal abscess and aneurysm, and stress produces peptic ulcer disease. So some general examination, you can check whether patient having anemia, patient having jaundice, angular cheilitis or ectopic glossitis, patient with iron deficiency anemia, raw beef coated tongue, patient with folate or vitamin B12 deficiency, whether patient having any clubbing, patient with IBD or chronic liver disease, patient might have koilonychia. In case of iron deficiency anemia, patient with malignancy or peptic ulcer disease or hookworm infection, patient might have koilonychia. Patient might have leukonychia due to malabsorption or CLD. Patient might have lymphadenopathy. You can find paraumbilical lymphadenopathy, para-aortic lymphadenopathy, the gastric and pancreatic cancer. Patient might have also edema in malabsorption syndrome, CLD, and nephrotic syndrome or renal failure. So there are some systemic examination we can see, check the abdominal shape, whether it's normal, patient is distended. Distended, we all know the patient having fluid, fat, fetus, and flatus. So diffuse swelling, patient have, or patient is, I have not written here, this is scaphoid abdomen may also present. Patient in case of malignancy, patient gets malignancy, we can find the scaphoid abdomen. Umbilicus, whether it is central place, everted or inverted, horizontal seat, patient with the movement of the abdomen, would check about the abdominal movement, whether restricted or not. In case of peritonitis, you will find restriction of the abdomen. In case of skin, you can check the Severity wart, Campbell-D Morgan red spots, and it is usually found in the Severity wart and Campbell-D Morgan spot in the elderly patient. And you can find some visible veins also in the portal hypertension, vena cava obstruction, and surgical scar and stomas. So you'll go next to the palpation phase. So palpation, you can see the signs of general palpation, superficial palpation and deep palpation. In case of superficial, yes. Yes,
sir, Campbell the Morgan jeta bollen sir, ota ashole ki jinishta?
Campbell-D Morgan is the red rose spot. The multiple red spot is a nodular lesion in the chest and abdomen. You will find invariably in many patients in your ward. Many patients you'll find in the Campbell-D Morgan.
Sir, কোন ক্ষেত্রে পাবো এগুলো?
It's a normal variance. It's a no pathological implementation.
আচ্ছা স্যার, ঠিক আছে স্যার। ওকে স্যার, ধন্যবাদ।
Superficial palpation and deep palpation. Superficial palpation, check the whether patient is generalized peritonitis is board-like rigidity or not. In deep palpation, check about any palpable mass, hepatomegaly, or any organomegaly. So they are important signs. We all know this is Pullen sign, the bluish periumbilical discoloration. We can give the retroperitoneal hemorrhage. Commonly, we see in the hemorrhagic pancreatitis. The Carr sign is a severe left shoulder pain. Usually, the left shoulder pain, the splenic rupture or ectopic pregnancy rupture. So it's a Carr sign, severe left shoulder pain. McBurn issue, you all know appendicitis. Everyone is from the third year. We know it's the appendicitis. The Murphy sign, you all know in the intercostal ninth intercostal. Murphy sign in the right hypochondriac area. Abrupt intercept inspiration, the palpation, the right upper quadrant, acute cholecystitis. Ilosua sign, hyperextension of the right hip causes abdominal pain. That is caused in appendicitis. And obturator sign, internal rotation in the fixed hip causes abdominal pain is appendicitis. Gray Turner sign, discoloration of the flank, you'll find that retroperitoneal hemorrhage in case of acute hemorrhagic pancreatitis. Chandelier sign, manipulation of the cervix causes patient lift of the buttock of the table. This is pelvic inflammatory disease. Ropsing sign, we all know. We will pace on the left iliac fossa and we find pain in the right iliac fossa, occurs in the appendicitis. So we'll do some percussion road, like shifting dullness, fluid thin, and upper border of the liver dullness. So auscultation, the bowel sign, we all see succussion splash in the gastric outlet obstruction. Other examination we do in the genitalia, hernial orifice, and pararectal digital examination. So this is an history, we are not going through it. There are some investigations. So whenever a patient comes to you with acute abdominal pain, then there is no clear evidence of peritonitis. Do blood test for him. First, as a medicine doctor, you think about patient whether suffering from acute pancreatitis. Go for lipase or amylase test. I will prefer lipase because amylase is raised in many other causes. If you get your lipase value normal, then check for erect posture. So you free air for perforation, or you can many things you can see in the erect posture X-ray. You will find the perforation. You can check patient having obstruction. You can find patient with colon cutoff sign. You can find patient with sentinel loop. So many things you will get. You can find stones. So many things will be revealed in the abdominal X-ray. So any patient coming with abdominal pain, to me, I first order lipase as well as chest abdominal X-ray, plain X-ray abdomen in erect posture. So if you don't get anything, you will go for sonography to check any gallstone or in gallbladder disease, and then contrast radiology for checking any perforation. If you don't get, go for CT scan to say pancreatitis, any abscess, aortic aneurysm, or you can find malignancy, different malignancies. If you still don't get anything, go for laparoscopy or laparotomy. In case of chronic or recurrent abdominal pain, in epigastric pain, dyspepsia, symptoms such of gallbladder disease, endoscopy or endoscopy and ultrasonogram. If you think this is a case of peptic ulcer disease, so you will not get anything in your investigation I have mentioned before. You have to straight go to endoscopy. Many patients will tell you, no, I will not go for endoscopy. Whatever is, I will not go for endoscopy. But don't forget, the endoscopy is the answer. There is no alternative of endoscopy. So in case of altered bowel habit, rectal bleeding, go for colonoscopy, and patient of suspected mesenteric ischemia, go for CT or MR angiography. In case of suspected IBD, check for colonoscopy or sigmoidoscopy and fecal calprotectin test. In case of upper abdominal pain, ready to the buttocks, ultrasonogram and CT abdomen. So check this X-ray. It's a plain film, small bowel obstruction. You can easily say fluid and air fluid level. Multiple air fluid level you are finding here. This is a case of small bowel obstruction. You can see in the right side, the featureless, and in the left side, in the right side, you can see the valvuloconniventis. What you can check in the X-ray on the left side, this you can see the gas under the gas under the diaphragm. This is rupture of the gas containing hollow viscous. In the middle X-ray, you can check the hostration under the diaphragm. This is called chiliditic sign. Chiliditis sign. This is not the perforation. Many patients, many doctors see this is a perforation. Check the gas shadow under the diaphragm on the left side, right side. You can see this is not perforation, but it is chiliditis sign. And in the right one, you can check the patient having dilatation of the bowel in the right iliac fossa. This is called sentinel loop. Sentinel loop, that is means when an inflammation in the gastric loop, anything in the abdomen, surrounding abdominal loop, gut loops will be dilated. So in case of appendicitis, you will find this sorts of sentinel loop. So look at this. Look at this picture. You can see this picture. Don't see in this. You can see this is multiple thumb printing. Like this is someone, look at this thumb. Look at this thumb. একটা কিট আপনি দেখবেন যে থাম্বের মধ্যে আপনার পেইন্টিং নিয়ে এর মধ্যে চাপ দিয়ে এরকম একটা ট্রি আছে, রাইট? এরকম দেখেন চাপ দিয়ে থাম্ব প্রিন্টিং করে ছবি আছে। So if you look at this is a thumb, this is a one thumb, this is another thumb. You can find the thumb printing. This is mesenteric ischemia. This is thumb printing side. Look at this. Look at this picture. This is thumb printing. You can find it in the gut. You can find the thumb printing side. And if you go for a CT scan, you find the rounded lesion. This is mesenteric ischemia. So you can see this. Suddenly, you can look at this. This is a transverse. Suddenly, there is the transverse colon is ended. What is this? This is a phrenicocholic ligament. And there's inflammation. In case of inflammation of the pancreas, there's a আপনি জানেন যে transverse colon এবং pancreas একসাথে লাগানো থাকে। এবং এটা ফ্রেনোকলিক লিগামেন্ট দিয়ে এটা ল্যাটারাল পারিস্পিনিক ফ্র্যাকচার যেটা সেটা আপনার লাগানো থাকে। যখন আপনি ইনফ্লামেশন হয় প্যানক্রিয়াসে, তখন আপনি যে ফ্রেনোকলিক লিগামেন্টটা আপনি ইনফ্লামড হয়ে যায় এবং সাডেন কম্প্রেশন হয় এই জায়গাটাতে স্প্লিনিক ফ্র্যাকচারে, এবং যার ফলে পরের দিকে আর কোনো গ্যাস সেটা পাওয়া যায় না। এইখানে আপনার সেন্টিনিয়াল লুপও থাকে এবং ডাইলেটেশন হয় প্যানক্রিয়াসের জন্য, ইনফ্লামেশনের জন্য, এবং সাডেনলি এইখানে দেখা যায় যে ফ্রেনোকলিক লিগামেন্ট ইনফিল্ট্রেশনের জন্য এইখানে কাট হয়ে যায় সাইনটা, স্পাজম হয় এই জায়গাতে, যার ফলে দিস ইজ কল্ড কোলন কাট অফ সাইন। And you all know this is Cullen sign and this is Gray Turner sign. And this is the cecal volvulus. And the bean-shaped dilatation of the cecum is called volvulus sigmoidal volvulus. Bean-shaped. So there is acute management. We are not discussing management here. General and the management is up to the cause of the patient. So what is general management is oxygen, intravenous fluid, just in case of patient antibiotic, and specific management according to the cause. So now I'm giving some quiz to you. Some quiz. A 35 years old male came to an emergency room with acute abdominal pain. 35 years old male, emergency room with acute abdominal pain, abdominal distension, vomiting for 3 days. Examination revealed presence of tachycardia, dehydration, and abdominal rigidity, and rebound tenderness. Best initial management would be, what is? Tell me one. 35 বছরের একজন মানুষ emergency department আসছে, patient with abdominal pain, distension, as well as vomiting. And examination করে দেখলেন যে পেশেন্টের ট্যাকিকার্ডিয়া, ডিহাইড্রেশন এবং অ্যাবডোমিনাল রিজিডিটি হচ্ছে এবং পেশেন্টের রিবাউন্ড টেন্ডারনেস হচ্ছে। So best initial management would be what? Anyone can tell me? Whether I'll go for IV fluid or CT scan, IV fluid followed by X-ray abdomen, direct CT scan, or ultrasonogram of the examination. Anyone can tell me?
IV fluids followed by X-ray abdomen.
Absolutely fantastic. So patient with having abdominal pain, distension, vomiting, so something a patient had rebound and patient have tachycardia, something happened, inflammation, that is peritonitis has developed. So we will get, so IV fluid is the must, patient have dehydration, so and followed by an immediate and X-ray, say check whether gas content perforation or obstruction is there. A 40 years old female had severe pain in the right upper quadrant with radiation to the back and vomiting for 6 hours. Examination revealed mild tenderness in the right upper quadrant. Best initial investigation would be what? X-ray chest, X-ray abdomen, CT chest, CT scan, and ultrasonogram examination. Tell me. Anyone can tell me.
Sir, ultrasonograph of
absolutely beauty, absolute beauty. This is ultrasonogram of examination. This is the right hypochondriac pain, something in the liver, gallbladder. We know gallbladder pain or subphrenic abscess. There's radius in the back as well as in the shoulder. So initial investigation will be ultrasonogram examination. A 65 years old male with history of thinning of urinary stream with intermittent wake up in the morning with lower abdominal pain and inability to pass urine. Examination showed suprapubic distension. Parrectal examination is likely to show carcinoma of the prostate, carcinoma of the rectum, benign prostatic hyperplasia. Parrectal examination is not useful in this case. What is your thinking? 65 years old male, thinning of a poor urinary stream, intermittent wake up in the morning, lower abdominal pain and inability to pass urine. Examination shows suprapubic distension. What is the thinking?
Sir, BPH.
Absolutely. Benign prostatic hyperplasia. আপনি তো সব পারেন. Excellent. A woman of 35 years of age comes to you with an emergency department with symptom of pain in the abdomen and bilious vomiting due to the distension of abdomen. Abdominal X-ray showed no air fluid level. What is the diagnosis? Anyone? So যদি আপনি চিন্তা করেন যে পেশেন্ট হবে bilious vomiting, so যদি bilious bile ওইখানে পর্যন্ত না যায় তাহলে তার bile vomiting হবে না, তাই না? তাহলে duodenal obstruction is the cause. Acute pain in the epigastrium radiating to the back after alcoholic binge in a 45 years male with severe vomiting. True is serum lipase is less helpful than serum amylase in making correct diagnosis. Serum lipase is more helpful than serum amylase in making correct diagnosis. Serum amylase is never helpful in such case, and C-reactive protein is not helpful in acute pancreatitis. What could be the cause? Anyone? So epigastric pain, patient radiating to the back, patient having history of alcoholic binge, male patient, severe vomiting. So diagnosis is pancreatitis, okay? And I told you that serum lipase is more valuable than amylase value. So serum lipase is more helpful than serum amylase in making correct diagnosis after 5 days. That is true. You got my point? So thank you.
Yes,
is there any question? Is there any question, please?
স্যার একটা কোশ্চেন ছিল, মানে আমার নিজের ক্ষেত্রে হয় স্যার মানে মাথার পিছন থেকে, বিশেষ করে ফ্রন্টাল সাইড থেকে অক্সিপিটালের দিক থেকে স্যার শুরু হয়ে তারপরে হয়তোবা যে কোনো এক সাইড, হয়তোবা লেফট হ্যান্ড অথবা রাইট হ্যান্ড, এদিকে হচ্ছে স্যার স্প্রেড করে। এটা আসলে কজ কি? এটা মানে মাঝে মাঝে আমার হয়।
আপনি কি রাইট আপার আর্মে পেইন রেডিয়েশন হয় না লেফট আপার আর্মে রেডিয়েশন হয়?
স্যার মানে যে কোনো একটাতে, রাইট অর লেফট আপারে।
রাইট আপার। আপনি অক্সিপিটাল হেডেক হয়?
জি স্যার।
occipital headache.
Yes.
So, are you having any anxiety, tension, all like this?
না স্যার, মাঝে মাঝে তো এমন থাকে, কিন্তু মানে ওই পেন হওয়ার সময় যে এরকম মানে ওরকম অ্যাংজাইটি বা কোনো টেনশন থাকে, ব্যাপারটা এরকম না।
It's difficult to see. We need to examine you. What is happening there? We need some examination of the neck as well as upper arm, both sides of upper arm. We need some examination to find out the cause. So
yes,
please ask me a question related here. So if there is no question, can I conclude the session?
Yes, sir.
জি স্যার। আর স্যার আপনাকে অনেক অনেক থ্যাঙ্কস স্যার, অনেক অনেক থ্যাঙ্কস যে মানে খুব সুন্দর করে স্যার ক্লাসটি নিয়েছেন, মানে একদম প্রথম থেকেই স্যার। আর হচ্ছে ওই মোস্ট ইম্পর্টেন্ট পয়েন্ট গুলো আসলে বারবার আমাদেরকে বলছিলেন স্যার। মানে বেসিক্যালি আমার মনে হচ্ছে যে এটা আমাদের অবশ্যই মানে অনেক হেল্প করবে, পরীক্ষাতেই হোক আর এমনিতে হোক। মানে প্রতিটা পয়েন্টেই স্যার আপনি বলতেছিলেন যে এই পয়েন্টটা অনেক বেশি ইম্পর্টেন্ট, ধরে ধরে বলতেছিলেন স্যার। এই জন্য স্যার অনেক থ্যাঙ্কস। আর জেনেসিস অনলাইন ইউনিভার্সিটির পক্ষ থেকে স্যার আপনাকে অনেক অনেক থ্যাঙ্কস, যে হচ্ছে আমরা বলার সাথে সাথে আমি দেখছি যে স্যার আপনাকে মানে ফোন দেওয়ার সাথে সাথে আপনি রেসপন্স করছেন, ব্যাপারটা অনেক ভালো লাগছে আমার কাছে।
থ্যাংক ইউ। আমি আপনাদেরকে বলি যে ধরেন যে ছেলেমেয়েরা যখন আপনার ক্লাসের জন্য বলে, ছেলেমেয়েরা যখন বলে যে তারা পড়াশোনা শিখতে চায়, শিক্ষকের কাছে এর চেয়ে বড় আনন্দের আর কিছু হইতে পারে না। এর চেয়ে বড় আনন্দের আর কিছুই হইতে পারে না যখন ছেলেমেয়েরা বলে যে আমরা স্যার আমরা শিখতে চাই, আমরা ক্লাস করতে চাই, আমরা এরকম একটা প্ল্যাটফর্ম তৈরি করছি যেখানে আমরা আপনাদের কাছ থেকে শুনতে চাই। রাজশাহী মেডিকেলের বলতেছে, চিটাং মেডিকেলের বলতেছে, বিভিন্ন মেডিকেল সিনিয়র টিচাররা কথা বলতেছে। আমাদের সমস্ত ছেলেমেয়েরা যেখানে যে মেডিকেল স্টুডেন্ট থাকুক তারা আমার ছেলে মেয়ে। সুতরাং আমাদের ছেলেমেয়েরা যখন আমাদের কাছে আসতেছে ক্লাসের জন্য, তাদেরকে কিভাবে আমরা ফিরাই দিতে পারি? তারা তো সব আমাদের ছেলে মেয়ে। আমাদের চিকিৎসা তো আপনারাই করবেন ভবিষ্যতে। আপনাদেরকে অসংখ্য ধন্যবাদ এবং জেনেসিসের কাছে ধন্যবাদ, এবং এরকম প্ল্যাটফর্ম যারা তৈরি করছে তাদেরকে আমি অত্যন্ত সাধুবাদ জানাই। আপনারা সবাইকে ইনভলভ করেন। আপনাদের যেই যেই পয়েন্টে সমস্যা আছে আপনার সিনিয়র যাকে করবেন তারাই আপনাকে সাহায্য করবে ইনশাআল্লাহ। এবং ভবিষ্যতে যদি আমাকে ডাকা হয় অবশ্যই আমি আপনাদের সাথে আসি ইনশাআল্লাহ। সবাই ভালো থাকবেন
ইনশাআল্লাহ স্যার।
থ্যাংক ইউ ভেরি মাচ। আসসালামু আলাইকুম ওয়া রাহমাতুল্লাহ।
আসসালামু আলাইকুম স্যার।
আসসালামু আলাইকুম স্যার।